I would also like to invite our chairperson for this session, Dr. Hemant Malhotra, who is a senior medical oncologist, and sir will be chairing the rest of the session.
Thank you very much. Good morning, everybody. Really impressed. The meeting started dot on time, so that is a yardstick of a good, well-organized meeting. So happy to invite the next speaker, Dr. Mohit Sharma from Delhi, and he'll be talking to us about the MARIPOSA study, which is Amivantamab and Lazertinib versus Osimertinib in EGFR mutated NSCLC. So over to you, Mohit.
So good morning, everyone. I thank the organizers, Dr. Nandini and Dr. Ashay, for the invite. So the first, I have two presentations back to back. So the first presentation is Amivantamab plus Lazertinib versus Osimertinib in the first-line EGFR mutant advanced non-small cell lung cancer with biomarkers of the high-risk disease. A secondary analysis from the phase 3 MARIPOSA study that was presented in ASCO 2024. So as we all know, there are multiple features associated with the poor outcomes in the EGFR mutant non-small cell lung cancers, such as brain or liver metastasis, baseline TP53 co-mutations, ctDNA shedding. They're all common in these patients. So in this study, it was assessed the efficacy of the first-line Amivantamab plus Lazertinib versus Osimertinib among the patients with these high-risk features. So this was the study design. Amivantamab, as we all know, is an EGFR MET bispecific antibody with the immune cell directing activity. Lazertinib is a CNS penetrant, a third generation EGFR TKI. And Amivantamab plus Lazertinib, it meaningfully improved the PFS and duration of response versus Osimertinib and MARIPOSA. These were the key eligibility criteria: locally advanced or metastatic non-small cell lung cancer, treatment naive for advanced disease, documented EGFR exon 19 del or L858R, ECOG PS0 or 1, and asymptomatic brain metastasis which did not require definitive treatment. The primary and the patients were randomized to Amivantamab plus Lazertinib or Osimertinib arm. Primary endpoint was PFS, and high-risk subgroups analyzed were brain mets, liver mets, TP53 co-mutation, detectable EGFR mutated ctDNA at baseline, and without EGFR mutated ctDNA clearance at cycle 3 of day 1, that is week 9. That the diagnostic tests used were ctDNA NGS, which was analyzed with Guardant 360, and exon 19 deletion and L858R ctDNA, and in the blood was analyzed at baseline and cycle 3 day 1 with the biodesix droplet digital polymerase chain reaction. Amivantamab plus Lazertinib, it reduced the risk of progression or death by 30% and improved the median progression-free survival by 7.1 months. So median follow-up was 22 months in the Ami and Laz arm, median PFS 23.7 months versus 16.6 months in the OC arm with a hazard ratio of 0.7. In the Ami Laz arm, 41% of the patients, they had history of brain mets versus 40% in the OC arm. And Osimertinib arm showed a median PFS of 13 months versus 18.3 months in patients with a history of brain mets. So Amivantamab and Lazertinib reduced the risk of progression or death by 31% in this subgroup. In the Ami-Laz arm, 15% of the patients had liver mets at baseline versus 17% in the OC arm. So OC showed a median PFS of 11 months and Ami plus Lev a median PFS of 18.2 months with the liver metastasis at the baseline. So Ami and Lazertinib reduced the risk of progression of death by 42% in this subgroup. So this was the patient disposition for the ctDNA analysis. The proportion of samples and detection rate were balanced across both the arms, and Amivantamab plus Lazertinib, it reduced the risk of progression or death by 30% over Osimertinib in the NGS and ddPCR ctDNA analyzable population, indicating that these subgroups were representative of the intent to treat population. Approximately 70% of the patients in both the arms had detectable EGFR mutated ctDNA at baseline, and more patients with detectable ctDNA had brain and liver metastasis at baseline. At cycle 3 day 1, detectable EGFR mutated ctDNA was observed in 15% of these patients in both the arms. So Osimertinib showed a median PFS of 14.8 months in patients with the detectable ctDNA at the baseline. Amivantamab plus Lazertinib reduced the risk of progression or death by 32% in this subgroup. And consistent results were seen in the subgroup using the ctDNA NGS assay with a hazard ratio of 0.71. We can see here with the detectable baseline ctDNA, Ami plus Laz has a median PFS of 20.3 months versus 14.8 months in the Osimertinib arm. Osimertinib showed a median PFS of 9.1 months versus 16.5 months with the Ami-Laz in patients without cleared EGFR mutated ctDNA at cycle 3 of day 1. So Amivantamab and Lazertinib reduced the risk of progression of death by 51% in this subgroup. These were the baseline demographic and clinical characteristics by the TP53 co-mutation status. You can see here. So Osimertinib showed a median PFS of 12.9 months in patients with the TP53 co-mutations at the baseline. So Amivantamab and Lazertinib reduced the risk of progression or death by 35% in this subgroup. The Ami plus Laz had a median PFS of 18.2 months in the TP53 co-mutated patients versus 12.9 months in the in the OC arm, while in the wild type TPR, Ami's Laz had 22.1 months of PFS versus 19.9 months in the OC arm. So in the PFS for patients with all these high risk features, it favors Amivantamab plus Lazertinib. So to conclude, so high risk features, they occur commonly in the first line EGFR mutated exon 19 del or L858R non-small cell lung cancer, which carry a poor prognosis with a median PFS of 9.1 to 14.8 months on Osimertinib. Amivantamab plus Lazertinib, it significantly improved the median PFS versus Osimertinib in these high subgroups which we have already discussed. And among the corresponding subgroups without high risk features, Amivantamab plus Lazertinib, it showed a consistent PFS benefit over Osimertinib. So Amivantamab plus Lazertinib, it produces superior outcomes in patients with and without high risk features and represents a promising new standard of care for EGFR mutant advanced non-small cell lung cancer. I guess it is already approved in US for the first line. So this is the second presentation which was presented recently at ESMO Barcelona into 2024. This is mechanisms of acquired resistance to first line Amivantamab plus Lazertinib versus Osimertinib in patients with EGFR mutant advanced non-small cell lung cancer. And this is an early analysis from the phase 3 MARIPOSA study. We all know that progression on Osimertinib is nearly inevitable due to acquired resistance that can be diverse and polyclonal. The most common EGFR TKI resistance mechanisms are EGFR and MET alterations. Amivantamab, a multi-targeted EGFR MET bispecific antibody with immune cell-directed activity, targets EGFR and MET-bait resistance upfront with the potential to alter the spectrum of acquired resistance. And Amivantamab plus Lazertinib, it significantly improved the PFS versus Osimertinib in the phase 3 MARIPOSA study, which we have just discussed, and this is now approved in the US for the first line treatment of EGFR mutant non-small cell lung cancer. In this study, it is reported the acquired resistance mechanisms for patients with disease progression on first line Amivantamab plus Lazertinib versus Osimertinib. The MARIPOSA study design, which we have already discussed. The ctDNA analysis, a total of 858 patients with treatment-naive EGFR mutant exon 19 deletion or L858R locally advanced or metastatic non-small cell lung cancer. They were evenly randomized to receive Amivantamab plus Lazertinib or Osimertinib. The paired blood samples were collected at baseline and end of treatment for analysis of detectable circulating tumor DNA by next generation sequencing, Guardian 360. All p-values were nominal, and end of treatment, it was defined as disease progression or treatment discontinuation or within 90 days of discontinuation. So MET and EGFR based resistance mechanisms, Amivantamab plus Lazertinib, it significantly reduced the incidence of acquired MET amplifications and EGFR resistant mutations versus Osimertinib. Acquired MET amplifications were threefold lower, and EGFR resistance mutations, they were eightfold lower for Amivantamab plus Lazertinib versus Osimertinib. There was no statistically significant differences were seen between arms for the other resistance mechanisms such as HER2 amplification or RAS-RAF pathways, PI3K cell cycle or TP. Amivantamab plus Lazertinib did not meaningfully increase other molecular escape pathways and had a low rate of TP53 RB1 loss that was associated with small cell lung cancer transformation. There was no clear resistance mechanisms were detected in 61% of the patients for Osimertinib and 68% of the patients for Amivantamab plus Lazertinib. And among patients with the known resistance mechanism, Osimertinib had a more heterogeneous mutation landscape than Amivantamab plus Lazertinib. So complex resistance was defined as having two or more resistance pathway alterations detected by the ctDNA. So Osimertinib had a higher frequency of complex resistance than Amivantamab plus Lazertinib. So in Osimertinib had 42.6%, while Amivantamab plus Lazertinib had 27.8% resistance in more than 2 resistance pathways. So lower rates of exon 19 deletion or L858R was detected in ctDNA seen in Amivantamab plus Lazertinib versus end of treatment. This we can see at the baseline, and see here at the end of the treatment. So Amivantamab plus Lazertinib, it had a deeper and more sustained EGFR inhibition than Osimertinib. So using ctDNA NGS analysis, Amivantamab plus Lazertinib significantly reduced the incidence of MET amplifications and EGFR resistance alterations versus Osimertinib. The MET amplification 4.4% versus 13.6% with a p-value of 0.017, and EGFR resistant mutations 0.9% versus 7.9%. And no significant differences were observed among MET and EGFR independent resistance mechanisms between the arms. Ami plus Lazert had a low rate of TP53RB1 loss, and Osimertinib had a higher frequency of complex resistance than Amivantamab plus Lazertinib. So Amivantamab plus Lazertinib's multi-targeted EGFR MET approach, it narrowed the spectrum and reduced the complexity of acquired resistance versus Osimertinib. Thank you so much for your patient listening.
Thank you very much, Mohit. We'll have the discussions at the end of all the presentations.